Hey, what's happening, everybody? We're talking with a trauma surgeon today, and I'm a big fan of HBO's The Pitt. I've seen season 1 and season 2, and it's all set to go for season 3. This has been known as, or hailed as, one of the most dramatic real-life medical programs on TV. I want to welcome Dr. Mark Kryskow to the podcast. I'm Slater, by the way, and we're going to talk about like a day in the life of a trauma surgeon and what it actually looks like.
Yeah, I think it's exciting.
Yeah,
I to be honest with you, I think the Pitt's pretty darn close. I don't watch the show, but in preparation for today, I watched a couple of experts, and even a couple of weeks ago, one of my colleagues from the ED posted something on LinkedIn saying, the Pitt just got this episode really right, and it was about like a stab wound to the heart with a pericardial effusion, meaning like the heart's compressed, and it was an impressive amount of detail that went into the episode, and it was really lifelike and appropriate. So I think they're doing a lot of things right. I think the one thing that is also right, it is chaotic sometimes.
Yes.
And scary. It's scary for staff. It's scary for the surgeon. It's fast paced. It's chaotic.
Season 2 starts on July 4th. They do an hour of, in real time. Every episode is an hour in real time in the day of life of the ED in Pittsburgh. But we'll talk about the summertime with increases in gunshot wounds, stab wounds. You just recently had you dealt with a person who was stabbed. What did that look like? And tell us please what happened.
Sure. You want to know what it looks like when someone gets stabbed in the heart? It's violent, right? So when someone comes in like that, obviously they're bleeding to death. You have seconds to make some decisions. You triage the patient, you get them lined up, big IVs, you're starting blood rapidly. There's a lot of people in the room. There's anywhere between 15 to 20 people required to take care of that patient. The trauma team, of course, the trauma surgeon, the emergency room providers doing the airway. The nurses are getting IVs, pharmacies there mixing drugs. It's a big deal, right? And seconds you need to be in the chest cracked open, so ripped open with retractors, deliver the heart into your hands, open the capsule around the heart, put a stitch into a hole, and if you're slow, if you don't get access quick, the patient codes and dies. So you don't have time.
So this particular case, the puncture wound was through the heart.
Into the heart, yeah.
Into the heart.
Yeah, and what that does, because there's a sac around the heart, it's called the pericardium, right?
Yes.
So it'll puncture the pericardium, and then when it punctures the actual heart muscle, every beat, some blood escapes, and it starts to compress around the heart and compress around the heart and compress and compress and compress until the heart can't beat anymore. The sac is able to keep a lot of that blood around it. You'd think it would just leak into the chest. Some of it does, but some of it just compresses the heart. It's called the pericardial tamponade. That was actually the Pitt episode I'm talking about.
Yes.
Tamponade. I mean, there's so much pressure around the heart from the injury because it's accumulating that it eventually stops the heart. So the goal is to get in there, open that sac, deliver the heart literally in your hands. You can start chest compressions, or it's called direct pericardial massage.
Wow.
To help the heart beat. So if the heart has stopped already, that's what you're doing. We do that, all year long. Patients have bad chest injuries. If we crack their chest and their heart stopped, we're not doing CPR externally. The heart's in our hands, and we're pumping on the heart. It's called pericardial massage. And we can often get it started just with our hands and some drugs. So anyways, this guy had an injury to the heart. So then your next move is to sew that up, which is technically challenging. If the heart's still beating, you're sewing on something that is beating and sewing it in a space that you can give the person a heart attack. There's vessels all around the heart. Everybody knows that, right? If you occlude one of those vessels when you're sewing the hole, or if the hole is right next to a vessel and you grab it in your repair, you give the patient a heart attack. They also die on the table. So, it's technically challenging. It's chaotic. It's violent for the room. Sometimes new nurses are in the room or other staff that's never seen something like this, and they got a chest wide open and a patient that's dying in front of them. So, yeah, that happens often.
Does the patient come in alive, or do they come in? Because I know there's a difference between like brain dead and and my other question was, with how much force do you have to injure someone to have that happen? I mean, that it has to go through skin, and does it like slip in between the ribs or something?
Sometimes it goes right through the rib or the rib cartilage. Yeah. It's a fair amount of force. To stab someone actually into the heart is pretty hard. That's an amount of violence. But there's blunt cardiac injuries that can do the same thing. Really sheared blunt injuries. Hitting a steering wheel hard.
Right.
But no, it's a fair amount of force. And penetrating, it's gunshot wounds will do it. Even a small bullet will pierce right through skin, subcutaneous tissue, ribs. A .22 will blast apart a rib and go into a heart, no problem.
Wow.
So, yeah, but a stab wound, that takes a lot of force.
So you have to sew up the injury, so to speak. What is that? Is it like floss? Is it like what is the actual thing you stitch it with?
Yeah, it's a permanent. It looks like, for lack of a better term, it's a monofilament. So it looks like fishing line. Essentially,
yeah,
it's called Proline. It's a permanent suture. You can do.
I was going to say it's permanent, so there's no like it doesn't sort of disintegrate or anything. Gotcha.
No, it doesn't dissolve. It's a permanent suture on the heart. You can do what's called pledgeted, so you can buttress it with certain soft pads so that you don't rip through the tissue. But yeah, it looks like fishing line. Proline.
Yeah. Another myth I looked up of trauma surgery is that if you make it to the ER in time, you will survive.
It's a huge yes. That's not a myth to be debunked. We used to call it the golden hour of trauma, but it's not an hour. You know what I mean? Depending on the injury, right?
Right.
So, in our community, penetrating is less than blunt, but if you have a blunt injury and you got a spleen that's cracked and a liver that's bleeding and you have an aortic injury or something from a bad car accident, if you're 10 minutes from the hospital, you're probably going to survive that. If your extrication is 20 minutes and then you got a 25-minute drive and you've been bleeding for an hour, that golden hour is a true thing. You've lost enough blood that now you're going to be what's called coagulopathic, and I can save you. I can get you filled with blood. I can stop all the bleeding, but because I've had to replace almost essentially all of your blood volume, sometimes over and over and over, you become coagulopathic and you just bleed because it's a coagulopathy. It means you don't have the right clotting stuff to stop other bleeding or even survive the operation that I just gave you. So, we have trauma patients that I've given 80 units of product to. Like that's 5 times that's like them losing all of their blood 5 times.
Wow.
You know what I mean? That's how long it might take to stop all their bleeding, right? And if they get coagulopathic during that resuscitation and during that process, it's hard to come back from, right? I can do all the stuff I want. So the closer you are, the less coagulopathic you're going to be, the lot easier that your post-operative recovery is going to be.
So why do you die when you lose blood? And that sounds like a simple question or an easy question for you, but like, is it just oxygen that blood carries going to organs?
Yeah. Your blood volume it's a volume that makes a pressure, and that pressure is required to bring the blood to various organs, right? If your brain doesn't have oxygen for even a brief period of time because it's not supplied by the blood, or not enough because there's not enough blood pressure to get the blood there, you become hypoxic and brain dead, right? Same thing with any organ. Kidneys hate not seeing blood. You'll get kidney failure.
Wow.
With just small clamp times, right? Like when we cross-clamp an aorta because something's bleeding and we have to cross-clamp an aorta above the kidneys, we have to be very careful about how long that clamp's there. We got to get our work done quick or we're going to give someone kidney failure. So even small, brief periods of time without blood, without oxygen, kills you, mostly because of the brain, anoxic brain injury. But the heart doesn't like it either. The heart supplies its own blood, right?
Yeah.
So when it pumps, it gets its own blood, right? So if it is not pumping and if it doesn't have a good pressure, the heart becomes ischemic, it dies. Right, then you don't have a pump.
What's ischemic?
No oxygen, lack of oxygen delivery.
Right.
So that's the whole purpose of blood, is to bring oxygen to the tissues. And if you don't have enough of it and your blood pressure is low enough, your tissues become hypoxic, meaning low O2 content.
Yeah.
They become ischemic and they die.
And how fast does that happen?
Every tissue is different. The brain is minutes, heart is minutes, muscle can probably go 6 hours or so before it's dead and irrecoverable, but every tissue is a little different.
So what are you most, what increases your chance of death the most?
Where the injury is. There are what we call surgical soles.
We'll switch over to gunshots. We talked about stabbings. We'll switch over to gunshots.
Yeah, no, it's a great question because that's what gets my my blood flowing when there's a gunshot wound to the right upper quadrant or close to it. I'd rather take one to the chest. I got a better recovery. I got a better option for that patient and saving that patient if they're shot in the heart than they are in the soul, I call it, the surgical soul.
Wow.
It's where the IVC lives. That's the biggest vein in your body. It's where the hepatic vein lives. It's where the liver is. Hepatic bleeding, hepatic vein bleeding, portal. That's the portal system here.
Upper right quadrant.
Upper right quadrant. You're shot there. The chances of us getting enough control and fast enough, really slim. And it's extraordinarily challenging to do. Extraordinarily challenging to do.
Does it matter the size of the bullet? I mean, that's kind of sounds obvious, but if you're shot with a 22, which is not that big of a bullet, it's not that big of a bullet.
No, it's tiny. Yeah.
Yeah.
But
compared to a 50 cal.
Yeah,
I'm just kidding.
I mean, a 50 cal is not going to work out for anybody. A right upper quadrant 50 cal just essentially cut the patient in half.
Kidding. 9 millimeter. Right, yeah. Like if they're shot with a 9 millimeter or something.
Yeah.
That's professional, Slater. Really nice. Yeah.
Well, no, I've been in the military for 20 years. I
didn't know that.
I know what a 50 cal does.
Oh, cool. Yeah, I didn't know. Yeah. Well, thank you.
That's a large round.
For your service. Yeah, no, I know. I was just messing around. But yeah, so
it matters, but not that more. You know, I've seen a 22 do as much damage as a 9. What a 9 does, or a bigger caliber bullet, is its blast radius inside the abdomen is much bigger. So it creates a larger blast radius, right? So more soft tissue damage, more chances of damaging another structure around said structure that is damaged. But a 22 to the surgical soul, to the IVC, or hepatic vein or portal vein or something like that, that's just as dangerous as a 9 to that area.
So you were saying that, what if you're shot just in the liver?
Yeah, that's probably not going to be a problem.
Not going to be a problem.
You're going to need to go to the operating room, but we're probably going to be able to control that. There's a lot of ways to control it. That's a very multidisciplinary control, actually, because my role in there is to get you open, pack it tightly, suture some of the liver. There's special sutures you can put in the liver, but you're suturing paste, right? The liver isn't something that you can close tight. There are lots of different ways that we try to stop liver bleeding, but often what we do is get it close to hemodynamic as possible, close to not bleeding a lot, and then we go to IR, interventional radiology, and we have them actually embolize some of the bigger vessels internally from the inside, from like wires. And what an embolization is they take a little wire, they go up through the groin, they go into the major blood vessel that supplies the liver, and then they just put a little glue in there or a little coil, and they stop the blood from even being able to get there. So, but that coordination's crazy. That means you're hitting the ED, you're rapidly resuscitating the patient, you're running into the OR, you're zipping them open, you're packing around the liver, you're running them over to their interventional radiology, you're hopefully getting them embolized. You might be running back to the OR after to fix some other stuff. It's an immense amount of coordination. And the resuscitation, when I say resuscitation, that means this patient's getting blood and plasma, constantly, and that's done by nurses and anesthesia teams and stuff like that. So there's a ton of coordination there.
What about if you're injured in the head by
that's a tough one.
Gunshot wound?
Yeah, if it's transtentorial, meaning it goes
transtentorial. You know what that is, Ryan? I don't know what that is.
You don't want that. Yeah, if it's in one side, out the other, through the brain, the amount of destruction there is pretty immense. I mean, that happens often. Usually it's self-inflicted, around here it's a self-inflicted gunshot wound. But for a lot of reasons, the patient, we can keep their body alive, but they're brain dead essentially, right? And we'll go through brain death testing and stuff like that. But you are usually brain dead, but I can keep you alive, if you will. That's an oxymoron. You can't actually say that. Once you declare brain death, the body is dead, right? But the patient doesn't have a beating heart. They can have other functional organs, right? But they're brain dead. You can't come. There are plenty of gunshot wounds to the head that do come back and do okay, right?
Yes.
You call neurosurgery.
But once you're brain dead,
no, you're dead. Yeah. The brain death exam is pretty regimented, right? Like there's a series of tests that we do, reflexes, cranial nerves, some scans that we do, apnea tests. There's a very regimented way to declare brain death. Once we've done that and it's been certified by two of us, usually it's the critical care physician and the trauma surgeon or both, or two of us have to certify it, and then it's death. That's actually when we write the death, the death summary.
Yeah.
We declare the time of death at the end of the brain death exam.
Now, another thing I was confused about was organ donation. That little thing on your license that says I'm an organ donor.
Yeah, we don't check that.
Yeah.
That's not a thing.
So how does someone?
You need to have so you're obviously not speaking for yourself, so you have to have a proxy, a healthcare proxy,
right,
to make that decision. We as trauma surgeons and hospitals do not engage the patient about that conversation whatsoever. There's a conflict of interest there. Obviously, if it was me and I had a young kid that was brain dead, of course I would want to have him try and save 6 other lives by, taking his kidneys and taking his liver and saving lives with this, right? But that's not up to me, it's up to the family. So you need a healthcare proxy, and then you're going to be approached by the organ donation banks, and they do all that coordination, and you have to say for your loved one. They don't care what the license says. You have to say for your license as the healthcare proxy or the guardian of that person that you want to donate the organs.
And the other thing I didn't realize is that the organs have to be if someone is getting an organ from a donor, that body is kept alive. I thought they took the organs out, put them in a freezer, and then gave them to you.
No. That is a live harvest. Yeah, well, it's not a live. It's not really a live harvest because the person's brain dead. But no, that is a body, a vessel that has a beating heart, adequate oxygenation, and we ensure that. Like, that's part of the organ donation process, is they need labs corrected. So like if the electrolytes are not on, if their sodium's low or their potassium's low, I correct those things in the body. Even though they're brain dead, I get those things corrected so that the organs are healthy, right? So the vessel is very much alive. The donator is not alive, but the tissue is alive.
Well, okay. All right. So you sort of bring the organs back to life.
I support them, right? So if someone takes their life and they become brain dead,
yes,
and we get to them early, the whole process of what we do in the trauma bay is that's what we're doing. We're giving blood. We've intubated them, so we're oxygenating their tissues. Their heart doesn't take a big hit because it's not injured. The only reason the heart would get injured is if they herniate. Right, if their brainstem herniates and then the heart stops, that's a different problem. But if their brainstem doesn't herniate and their heart doesn't stop, their organs are going to be healthy. Their kidneys wouldn't even have taken a hit.
Yeah, what are the most donated organs?
Probably kidneys, liver. But everything can be donated. Tissue, skin. Eyes, corneas. Like everything can be donated. There's transplants of most tissues now. Bone can be harvested and then kept for grafts. But
what if the guy was a big drinker? Do you tell?
That is all tested. So when the organ is harvested, they biopsy it and they test it. The organ might not be used. It might go up for auction, so to say.
Yeah.
And that's what those systems do. Transplant centers can log in and look at the quality of the tissues and the biopsies of each thing, and they say, I want that one, that's good, or I don't know, that's pretty dicey to transplant into somebody. So we test for that when we harvest the organ.
So you have to deal with patients that are, reaching death and do die right in front of you. Are you religious at all?
No, I'm not religious, but it's a daily occurrence is death. Yeah, it's part of the job.
Yeah, it's part. So like you never see the soul leaving the body or experience any. I hear things like that. I was in the room when I saw the soul leaving the body. You know what I mean? Like,
no.
No, that doesn't happen. Actually,
no. Well, it hasn't happened to me.
It hasn't happened to you, right?
It might have happened to somebody else. No. There's a lot of spiritual people in what we do. Fostering, people's end of life is what I like to call it. I do a lot of end of life care, and but no, I've never seen the soul floating away from the body.
Yeah.
I'll tell you if I do one day.
Yeah,
I'll know.
No presence, nothing, huh?
Yeah. No. But I've had weird circumstances like that, like seeing somebody and just getting a weird feeling for no reason, and then in 45 seconds they're dead. Like when they were just talking and healthy. You know what I mean? Like, there's been weird circumstances, and I don't know what that's all about, but that happens.
That happens, yeah.
Yeah.
Are you the one who has to tell the family that the person has passed?
Yeah. You know, those are the hard conversations, when it's, especially when it's a kid. Pediatric trauma is the worst, right? Because the family's not in the trauma, and that's usually when it's happening. It's either in the trauma bay and the operating room is when I lose somebody. If I can get them upstairs to the ICU, I got a better chance. Plenty of people die in the critical care unit, but you usually lose them in the trauma bay or the OR, and you just come out and you just got to talk to the mom who's falls apart, dad who's falling apart, the rest of the family, and you just got to support them. You try not to talk too much, and they just got to know that you tried everything, and they're all in shock, and it's hard to swallow. It's hard for the staff to swallow because it's traumatic for them.
Are you guided on that? Like, do you guys like take?
Yeah.
Like, does the language sort of change? Like some sort of like guidance or curriculum where you're like, listen, this is the way we want you to say it, or do they just sort of trust you and to?
Yeah, I mean, certainly there's like in training, there's guidance for the difficult conversation, difficult family conversation.
Yeah.
I mean, that's kind of what you do in residency. You see thousands and thousands of patients, and you have thousands of difficult conversations about end of life. That's what surgical residency is.
Yeah.
And then you go on and do a trauma fellowship, and you're doing this so much that you develop, each clinician develops their own way to kind of approach that, but there is guidance, there is formal training for it. But we all have our own various styles of the deliverance of bad news.
And would you say most people take the information fairly well, somewhere in the middle, really,
it's
crash
all over.
out, it's all over the board?
It's all over the place. And it's, and we don't take offense to that, right?
Yeah.
Like, come on. I mean, you just lost your son. Or,
of course. Yeah.
Anger's okay. You just support them through their emotion, as much as you can. But no, that's very real, and it's all over the board. Some people are totally not understanding, right? They're understanding, but they're much more. They're just obviously they take things easier than others, and they're less hysterical and whatnot. But it's tough. That is the hard part of the job.
I mean, you must be used to it in a way, though. I mean, really, if you do something every single day, it must be like, oh, okay, I got to go tell so and so that their loved one just died.
Yeah, no, that you become. I think that all surgeons would say that you become not cold, but you just become like, this is a part of my job. Just like anything that people do in their jobs, it is a part of my job, and you do have to disconnect. If I lost it every time I had to do that conversation, I would never sleep at night.
Yeah, no, totally. Yeah.
Like it becomes self-preservation. That's probably how you learn it, and in training. Because I guarantee you, the first time I had to do it when I was like an intern or something like that, I was probably crying.
Yeah, of course, yeah.
But just like anything, you develop that kind of like defensive mechanism that it can't be like that. This is part of your job. The more reps you get in this job with anything, certain operative procedures, the more natural they feel, and actually become better at it. I really do believe that I've become so much better at delivering that type of, even if it's not even about a death, even if it's just about complication, just speaking matter of fact, being there to support them, you become really good at it.
The other thing I was wondering is the hours of the job, right? So when you're on call, obviously a traumatic injury can happen anywhere, anytime. You're not like sort of waiting. Like, what are you doing when you're on? Like, you're on duty right now.
Yeah, I'm on call,
and you have to be so within proximity to the hospital, right? Like how?
Yeah, that's for me. Well, it depends. It's a complicated conversation, but if you're just talking about my situation, which is at a level 3 trauma center, we don't take in-house call. Right? So some trauma surgeons at various, depending on the level of trauma center they're at, they take in-house call. They literally are standing around for 24 hours. And they're not standing around. Let me make that very clear.
Right.
They're very busy, but they are a shift. They are there for 24 hours, and then they go home and get some rest. Right? That is not this trauma center. This trauma center is I'm on call, and I can go home. I can, I see you. I see you at my son's baseball game. I saw you last night at my son's baseball game.
Exactly.
I was on call, right? I can be there as long as it's 30 minutes from the hospital. I got 30 minutes response time for a level 1 trauma. If somebody, and the other thing is too, is I'm the only trauma surgeon in Berkshire County. So there's a lot that can come in here. I'm not the only trauma surgeon covering call, but I'm the only boarded, I'm the trauma medical director here. There's people that share the load. I don't have to take call every night. But during the day, I'm on call every day. And then on the weekends, it goes to, that's kind of cool about this community, actually, if you want to talk about that for a minute. People covering trauma call, the trauma surgeon on tonight is a neck surgeon. The trauma surgeon on call last night was a bariatric weight loss surgeon. The trauma surgeon on call the day before that was, I don't know if it was our colorectal surgeon or not, I can't remember who it was. But it's a shared responsibility. They're all board certified general surgeons. They're credentialed in trauma care and trauma surgery, but they might have a different specialty. That's how it works in smaller trauma communities like this.
Yeah.
At a level 1 trauma center, Bay State or somewhere else like that, it's a bunch of board certified trauma surgeons that share that load. There's 10 of them, you know what I mean?
So when we hear that a patient has to be airlifted to Albany or airlifted to Springfield, how serious is the injury?
It's the coverage. So for our community, there are gaps in coverage. Sometimes we don't have a vascular surgeon on call at night. And so I'll take the patient to the OR. They got a really bad vascular injury. I can stop the bleeding, but maybe the reconstruction would be best done by a specialist, right? So I'll do the initial care, and then I would ship that patient if we didn't have coverage for that specific subspecialty. The biggest gap for the community was, but we've actually righted that, is neurosurgery. There were a lot of days during the month that we didn't have a neurosurgeon. So it might not even been that much of a big injury, but we didn't have a neurosurgeon to staff it with, so the patient had to be shipped for it. So it's all about gaps in coverage. And we're actually writing a lot of those right now, so that's great.
And you're 80 hours a week?
There's no cap for us.
Yeah.
That's trainees. So when you're in training, you can't do more than 80 hours. And it's actually, the real rule is 80 hours averaged over a 4-week period. So they can do 120, which often our residents will do. They'll work 120 hours, and then they'll try and catch back up on the week after. They'll try and make it lighter. And that's pretty strict nowadays. Then it used to not be that way. They used to just work 100 hours a week, period. And now it's pretty balanced, but there's still really heavy weeks. But in attending, no, I can be on call on a Monday. Well, a good example is I'm on this weekend. So on Friday morning, I'm going to start call. And I'm not going to end that call until Monday evening. So I could feasibly work for 4 days straight and never leave the hospital. There are times that you've been in the hospital the entire time. You might try and sleep on a couch or sleep in your office, but there are times that you will work that whole stretch. And that's only the stretch going into your work week, because by the way, I got to work that whole week, right? So So now it's Monday and I got to go to clinic, but I haven't slept any because I was on call for 3 days and operating all night long in the middle of the night. That's when bad things happen, by the way. It's not like a bad thing happens at midnight. I mean, at noon. It happens at midnight.
When you get no sleep.
Yeah. So, and that's when emergency general surgery happens too. People wait all day to come into the emergency department, and now it's 8 o'clock at night, and now you got a perforated something that you got to bring to the OR, and then a level 1 comes in, and then then you're up all night, and then you got to go to work the next day.
How do you deal with that?
There's no cap for surgeons. We're not pilots.
Yeah.
We work hundreds of hours a week.
How do you deal with that and balance family life?
That's why I work where I work now, because I just take advantage of the time that I do have, right? And you build something close to the hospital that's fun and meaningful, and you spend as much time you can as your kids, but your family does take a huge hit for sure. I mean, my wife has to do
because you got 3 kids, yeah?
4.
Wow, you got 4?
Yeah, we're crazy.
Yeah, you are. Yeah, and you're a younger guy.
I took care of that.
Or did you just look, or do you just have no gray hair?
I'm 43, so it's
43?
I'm
okay,
not.
So I'm 45, so yeah, we're kind of the same age, but yeah.
Yeah, no, that's hard if you don't. And I mean, look at the divorce rates in trauma surgeons and
they're high. Yeah.
They're very high. Yeah. Because
interesting. Yeah.
sometimes you're not home and you're missing a lot of stuff.
Yeah.
And you put a lot on your loved ones. Like, I don't know what kind of bank we use. I don't pay bills. I don't do the tax. Like,
he just brings home the bacon.
I mean, I don't know where anything is. You know what I mean? Like, so, like, my wife does everything. She's incredible. So yeah, you need a strong relationship for sure. Does
she work?
She did. She works 3 days a week.
Unbelievable. Yeah.
She's on it. She's cranks.
Yeah.
Our jobs are chaos, right?
Yeah.
And it's not just the chaos of the trauma bay. That's what's glorified on TV. I love that part because it is real. It's chaotic in there.
Yeah.
And you got seconds to save a life and make really good decisions or bad decisions, and your patients are going to either live or die from the decisions that you make. But if you make the right decision, then you end up in an operating room and you got to make really complicated decisions, and you have to be talented about, you can't just say, I'm going to do something. You know what I mean? Like, you got to make the right decisions. You got to be talented. There's endless amounts of them, and the wrong one you make will make the difference of a life or death, right? In a bad trauma.
Give me an example.
A big part of what I do as a trauma director is I review cases, right? And so if a good example is access. If somebody is shot or stabbed in the chest, the access to get to said area, meaning a median sternotomy, do I cut the bone in half like this and rip the chest apart like this? Do I cut the bone apart like this and rip the part like this? It gives you access to different vessels, better access to different vessels, right? If you guess wrong, if you make the wrong incision, you're pretty much hosed. And sometimes you make the wrong decision. Sometimes you think it's all the swelling in the neck, the bullet must, because you don't have time to go to a CAT scanner. You're not taking the patient and miraculously scanning them and saying, oh, I know where the bullet went. You know what I mean?
Yes, of course.
That's not how it works. They're dying, so you're ending up in an operating room or you're staying in the emergency department, and you got to make the right access incision. And if you make the wrong one, you're going to lose control. Even if you figure out how to get to the right one in the end, you've already lost enough blood and you've already made the wrong decision. So being a trauma surgeon is a lot like, I used to put my head down at night when I was on call and I would rehearse what I would do if. What incision am I going to make if I get a gunshot wound to the right? Am I going to choose a median sternotomy or am I going to do a left thoracotomy? What am I going to do after that? Just like an athlete rehearses for their game or their process or their shot or whatever, they do a lot of mental, rehearsing. We do the same thing. How am I going to get this in control if this happens? What if it's this? What if it's this? That's how you kind of train and train and train. Eventually you don't have to do that all the time, but you still can make a wrong decision. So you got a second to make the right decision and the right access. You make the wrong one, the patient's going to die.
All right, I think we'll end it on 5 myths.
5 myths.
5 myths of trauma surgeons. All right. Number 1, trauma surgeons are adrenaline junkies. They absolutely love the chaos.
All right. Well, I mean,
how many Monster energy drinks is Dr. Mark Kryskow drinking during the day?
So I'm an avid ice climber. I climb as much ice as I can. I'm an avid mountain biker. I travel the world.
You're an ice climber?
Oh, yeah.
Those things with the big spikes on the shoes?
Yeah. That's what I did for the Army, actually. I was a mountaineer.
Wow.
Yeah.
Where do you climb ice?
All over the world. Yeah, half the destinations I make are to go find a big waterfall and climb it, hundreds or thousands of feet. But yeah, New England has some of the world's best ice, actually.
Wow.
Yeah, New
I
Hampshire.
did not know that about you.
Oh, yeah. Yeah, it's a huge part of it. My wife and I are avid climbers.
Wow. Just ice?
Yeah, but
or just climbers?
Just climbers in general.
Yeah.
But ice is probably my favorite.
Right.
Yeah, my destination. I don't make many destinations for rock anymore.
All right.
But I mountain bike a lot. I do, I don't know if I'm an adrenaline junkie, but a junkie, if you will. But I'd say, a lot of them are like that.
Yeah.
They're pilots, they're base jumpers, they feed on that, right? That's kind of why we're in this. We like that fast pace. We like to be the person to make that kind of pressure decision. That's probably why we do it. It's got to filter us somehow, right?
Right. Anybody smokes cigarettes in the trauma surgery?
Oh, I've had
anybody packing lips? Anybody got the little
Of course.
the nicotine pillows in their bottom lip? Anyone?
Of course.
Yeah, of course. Yeah.
Oh my gosh, yes, 100%.
Anybody gambling online? Anybody? What's right?
I mean, you really want to get into the nitty gritty of that question, or what?
I know.
The answer is yes.
Yes. All right. Myth number two. They're like the super confident, godlike doctors on TV. The Noah Wiley, the Dr. Robbie Rabinoviches of the world, right? Yeah.
I don't know.
Or
if that's
George Clooney from ER, right? Of course, yeah.
I mean, inherently, you have to be confident.
Yes,
you know what
of
I mean?
course, yeah.
And if you're not, you wouldn't be in the position. Like, you just wouldn't be there.
Who wants an insecure doctor? I don't know if I can do that.
I don't know.
I can't figure this out.
Can someone else do this for me?
Right. I know.
Yeah, no, but a lot. That is a good question because it's how we weed people out, right? Like this job can't be done by everybody. You don't want it to be done by everybody. Right. That would be bad. The
insecure doctor.
I tell that to surgical trainees all the time. This is like Ranger School. You're not supposed to finish if you're not supposed to be here, right? Like it's not for everybody.
Right.
So yeah.
Same for the faint of heart.
Yeah, and maybe that's true.
Number three, they're always running to the OR for dramatic surgeries.
I mean, running would be probably not true.
Right.
But yeah, we run all, I was running yesterday to the trauma bay from the office. I was in the office. I said to the patient, hey, someone just get by a car. I'm going to run to see it. And I'm running the OR.
And you're running, right. You can hear the floor squeaking just like the,
Yeah, that's true. Driving fast.
Another myth, one heroic surgeon saves everyone in the room.
That is a total myth.
Yeah.
That is the myth, because it's not one. Like, I might do one part, but there's a huge team here, right? And trauma surgery is, yes, I'm the lead of the room and the lead in the OR, but there's a billion times that I'm calling in a second hand, a vascular surgeon, a neurosurgeon. You work with a huge team. So it's, trauma surgeons are like, the coach of the team, but they're not doing it all.
Right. And the last one, I think we addressed this earlier. If you get to the ER fast enough, you'll survive.
We did talk about that. That's not a myth. That's very true.
Yeah.
Faster you are to the hospital with a gunshot wound or a stab wound, the likelier that you're going to survive. If you have a bad injury, of course. I mean, that's just true.
Car accidents.
Yeah.
What does that look like? What is the most severe car accident? And
they're way worse than penetrating injuries.
Yeah.
I mean, blunt is injury. So it's blunt and penetrating injury. Those are the two types of injury, and that's how we kind of categorize them, right? Blunt injury. If you die of a blunt injury in the field, we don't even try to open you up and save you because there's so much catastrophic damage probably from your blunt injury that made you code and die that we cannot deal with. If you die of a penetrating injury in the field within 10 or 15 minutes, we're going to consider opening your chest and trying to start your heart. Not with a blunt injury. It's catastrophic. I mean, the biggest injuries I've ever seen are car accidents or people getting hit by a train. Like, think of how much damage that does.
Yes,
that's just
course,
a blunt injury. But every organ is cracked in half. Thousands, hundreds of fractures. Spinal column injuries, spinal cord injuries.
Yes,
those things kill you quick. Right? You can get shot 2 or 3 times, and there's so many people that get, like, you'd think they'd just be dead, but the bullet misses the heart by a millimeter.
Right.
And it travels through their whole chest, around their heart, into their abdomen, misses every big vessel, might hit a spleen, and all I doing is go and take a spleen out. It takes me 15 minutes, and it could have killed them.
Unbelievable.
And it's always 1 millimeter. A guy shot himself with a nail gun last week. It went in through this chest, past his heart, like around his heart, didn't hit the esophagus, didn't hit the aorta, came out, just went through his stomach, the front of his stomach, the back of his stomach, and then came out through his rib, right back here. It missed everything. And it's a nail gun. It could have destroyed everything in its path. It kind of just went all the way around. All I did was fix his stomach up, and he left the hospital in a couple of days, right? So blunt injury, that's not how it works. If you get a big enough blunt injury that's making you code or making your blood pressure low, you got a lot of systems down. Your spine's probably cracked in half. You got a spinal cord injury, you got a head injury, you got blunt organ injuries, blunt cardiac injuries. Those are way worse.
All right, there he is. Dr. Mark Kryskow, everybody.
That was fun.
I appreciate your time.